would like to ask a question to my US colleagues on this topic. At the moment, in all-day clinical practice, what we are doing is try to get a biopsy from the metastasis we can reach, let's say lymph node or liver or whatever. What are we doing at the moment from this biopsy? ER, PR, Ki67 and HER2, period. Now, tests are coming, and have been approached by Foundation Medicine, and I did already some of these tests to look for actual targetable mutations from the metastatic side. Now, since these tests are coming, as usual almost always, from the US and swept over the ocean, and I'm about to learn, are you using these tests? Because Hope and Joyce, it's nice to have ER, PR, Ki67 and HER2, but we know that the world is much more complicated in the year 2017.
Mm-hmm. Yeah, I am using both of the biopsies. If we're going to go to the trouble of getting a biopsy, I will usually send it off for next-gen sequencing. But I think the most exciting thing in my practice is the serial determination of ctDNA. You know, in the blood, we're being able to get that Garden or Foundation Act right now to because, and you say, well, why are you doing that? You know, I mean, is that a waste of resources? And I think the main thing for me is HER2 mutations are probably the actionable, because
which we'll get to HER2 mutations.
Yeah, we'll get later.
Right.
But also, I'll tell you, I'm getting it quite frequently when patients are progressing on CDK4/6 inhibitors, because I do really want to know what resistance mechanisms.
Good.
And I'm actually working with Aditya Bardia. We've noticed some RB1 mutations coming out. Again, this is just small. These are just small anecdotal reports at this time. They're hypothesis generating, but anyway, it is a good way for us to start to query, you know, what are some of the resistance mechanisms coming up.
But in the U.S., it's not standard of care.
It's not standard of care.
It's still somewhat difficult to get it paid for by our payers.
But I have to say, not being standard of care, I'm hard-pressed to find a patient who hasn't had it sent.
Right,
and people
absolutely,
have it sent on multiple tumors.
I agree.
And I would say that the number of patients for whom there are actionable mutations is vanishingly small. You know, we all remember is the 1 or 2 patients where we found something, and it's really exciting.
Okay.
But they're small.
But I would say, again, we'll come back to this, I think, when we talk about HER2. At least in my experience, the way I'm starting to think about this is that I think that ESR1, I think, will be actionable at some point. I mean, do we do we change the fulvestrant, as we'll talk about in a minute, or do we continue an AI? That's number 1. Number 2, I think HER2 tyrosine kinase mutations are probably a little bit more frequent than we believe. You know, would we switch the patient potentially to a HER2 tyrosine kinase inhibitor? And last but not least, something we don't talk about is ER amplification. And I think it turns out that people who are ER amplified may actually respond to high-dose estrogen. So, you know, there's a lot of things in there that are potentially theoretically possible, but we'll talk about that a little bit later, I think, when we talk more about HER2 and triple negative and bring this back. But we've talked a little bit about resistance, and I think we kind of want to bring this back to some practical kind of things that have happened. So the first thing is to talk a little bit about Paloma 2. I mean, was anybody surprised that Paloma 2 pretty much replicated Paloma 1? You know, Michael?
I was not surprised.
No, I think none of us were surprised by that. I mean, that's
also, if you do the trials and you have people who progressed on tamoxifen to develop metastatic disease and are still on 4 years later, longer than they were on their adjuvant tamoxifen.
Correct.
You know?
Something is going on that's good. And so the next question is really talking about resistance and various mechanisms is ribociclib. I mean, last year's ESMO, we saw the first data for Mona Lisa 2. Does someone want to comment on that? Michael, do you know about the design of Mona Lisa 2? Do you want to tell her?
I think on this table are sitting people who were on the trial.
There we
and,
go.
they might be the specialists to comment.
Design?
Well, I was not contributing to the trial, but I think I know the design. I mean, it was pretty similar to the Paloma 2, and it is single agent letrozole versus the combination of ribociclib and letrozole, and the results, I think, were absolutely confirmatory, very reassuring. Again, showed that incredible 10 to 12 months shift of PFS, which we have not seen, actually never seen
Right.
Because when you look at tamoxifen or AI, I mean, we were happy about 4.5 months and all of this. So kind of jump-starting luminal breast cancer into the ballpark of what we have seen with HER2
Right.
and others.
Absolutely.
So I think for me as a clinician, this was extremely reassuring.